So this is a part of a bigger study treating mostly myeloma patients, being much more common plasma cell disorder. It's an academic CAR-T that we locally produced, anti-BCMA CAR-T, 401BB co-stimulatory second generation CAR-T. And we have a study that started with the phase 1A and then 1B, and now it continued to a phase 2 study. We treated over 80 patients, and we updated now the results and presented here for the first 50 myeloma patients treated with the full dose. But you asked about amyloidosis patients, so we included in our study AL amyloidosis patients, and we already treated 9 patients thus far. It's not a big number, but it's a rare disease, and I think it's kind of the first proof of concept for this therapy worldwide. There was one case report of a patient with myeloma and renal amyloidosis that I'm mentioning in my presentation, but I think it's kind of the first proof of concept. So focusing first on safety, because it started with the phase 1 study, right? And this is maybe the main concern in this disease. So we did include and enrolled quite frail patients. 7 was actually on study and 2 was actually on compassionate basis, treated on compassionate basis. They were ineligible for the study, one because of severe MDS that he had, and the other patient was in a very bad performance status. And 7 of the 9 had cardiac disease, included myostage 3A and 3B. So very advanced patients with median 6 prior lines of therapy, and as I said, quite sick with mostly with the cardiac disease. And from the safety standpoint, there were of course CRS. 7 of the 9 had CRS. It was mostly grade 1 and 2. We had 2 grade 3 CRS, but it was manageable with frequent use of tocilizumab, and there was no there were no cases of ICANS. Hematological toxicity was much less severe than is seen in myeloma, and we assume that this is because that the marrow reserves in amyloidosis are usually better compared to myeloma. They have a smaller clone with less burden of disease. They start with higher blood counts. And indeed, we saw some grade 3 and 4 cytopenias, but less than in myeloma, and they were less durable, so it resolved earlier. What we did see in our study in a few patients, I think in 4, if I'm not 3 or 4 of the 9, is worsening of pre-existing involved organs, so heart or kidneys, heart failure right before infusion or right after infusion, kidney failure, and these were all manageable with supportive care and reversible, but I think it's something that we should bear in mind that can happen in this journey of patients undergoing CAR-T. So it was overall, I think, quite safe and not very different from myeloma. Regarding responses, so we had 100% response rate. All 9 patients responded, and 6 of them had a complete response, and 5 of the 9 were MRD negative at 6 were MRD negative at day 30. not all responses were durable, or I think most of the progression-free survival is not very durable, just because many patients unfortunately died of heart disease in the first year. Some of them, when they were on remission from the disease, on response, just because of pre-existing very severe heart failure, they had like sudden death while in response, some of them. So I think the main take-home message from here, from the safety standpoint, that it's overall safe even in very severe heart failure, frail patients, and it's extremely efficient. But if we want also to have organ responses, I didn't mention many of the responses were already translated to organ responses. So if we want to have durable responses for these patients, if we want to have organ responses, and of course quality of life and overall survival benefit, for sure we need to give it earlier and not after 6 prior lines of therapy. But it's a proof of concept.